Good afternoon. Hello. We'll get started in just a minute. Okay, why don't we get started? So, hi everyone, and welcome to the ALD Connect Bootcamp for men with AMN. My name is Tim McGuire. On behalf of ALD Connect, I would like to thank you for participating in this session about embarrassing symptoms. Today we have Dr. Pablo Gomery, who is a urologist at Massachusetts General Hospital in the Department of Urology. And we have Camille Kaur, who is a medical student at the University of Rochester School of Medicine. She previously worked with Dr. Florian Eichler, and she was a project manager at ALD Connect. So I'd like to just reference, and I'm Tim McGuire, I'm AMN patient and also a board member at ALD Connect. I'd like to just note that the webinar is for informational purposes only. The discussion is not intended to be a substitute for professional medical advice, diagnosis, or treatment. If you or a family member are ill or suspect that you're ill, seek professional medical immediately. ALD Connect does not recommend or endorse any specific physicians, treatments, and procedures on products, even though they may be mentioned on this webinar. Any questions can be submitted in the chat, and we'd encourage you throughout to put your chat, and then I'll in between speakers and at the end, I'll read some of the questions. At this point, I'd like to turn it over to you, Dr. Gomery. Oh, I'm sorry, we're going to start with Camille. Camille's going to get us started, and she has done extensive research and on some of the urological issues. And so, Camille, with that, we'll turn it to you.
Thank you so much, Tim, for that wonderful introduction. I am so excited to be here and to reconnect with many of you again. As Tim mentioned, I worked for 2 years at Massachusetts General Hospital with Dr. Eichler, working on a project with him and Dr. Gomery on urinary and bowel symptoms in adult patients with ALD and AMN. And I'm really excited to kind of continue working on that project throughout my time in medical school. So what I would like to start with before sort of discussing some of our research is just a note, I think, to the power that you all have within, ALD Connect as an organization. And so this project that we'll discuss today, really was born out of your ideas and the topics and questions that you all brought up at ALD Connect meetings, the annual meeting, patient learning academies, community calls, and many of you in our MGH clinic. And so, I think that really is here a testament to the power of the rare disease community. And, just know that this was something that we were trying to do in response to your concerns that these symptoms weren't, adequately being studied or addressed. So we definitely welcome your continued feedback and, keep bringing up those important questions, because that's how we ultimately find our new research questions. So to talk a little bit more specifically about our research, so the study that I'll discuss today, we studied about just over 100 patients, adult men and women with ALD and AMN. And we used a couple of different components to study the prevalence of urinary and bowel symptoms, to study their severity, the impact of them on your quality of life, and different medications and interventions that may be helpful in managing those symptoms. So first, we focused our efforts on a retrospective medical review of patients who were seen at Massachusetts General Hospital. We used those records to get a general sense of how prevalent, how common these symptoms were, and how, roughly what age they were first presenting. Then, and with the help of, I'm sure many of you on this call, we distributed a survey to our patients and the ALD Connect community to sort of fine-tune our understanding of symptoms based on, your reports. And so we gained a lot of insights through that method and really points to learn from. The final component is a study called a urodynamic study, which we'll talk a little bit more in depth as we go on. But this is a type of study that can be done by a urologist, such as Dr. Gomery. And so we were fortunate enough to be able to sort of look back and review the records of patients who had had this type of study done, and just get a sense of what were the most common patterns of symptoms. So in terms of our findings, and again, I really want this session to have lots of time for questions. So this will really just be a brief overview, but please do ask us any questions that you have. So we found that roughly 3/4 of adult patients with AMN have at least one of these urinary and bowel symptoms. The most common pattern that we saw was a pattern of urinary urgency followed eventually by urinary incontinence. So sort of the sense that you need to use the restroom very urgently, and then eventually, as that progresses, developing to incontinence. Interestingly, in our AMN population, we find that these symptoms are even further worsened by the fact that we know AMN patients to have challenges with walking, with balance. And so, to have this sense of urgency and then also have trouble getting to the restroom on time, just further compounding the effect of those symptoms. Roughly, we found that males tend to experience their first urinary and bowel symptom around age 30. And we found that just over half of patients actually experience at least one urinary or bowel symptom before other signs and symptoms of AMN. So before those, difficulties with walking or with balance, which we thought was interesting. That was unexpected. We also asked patients about how their quality of life was limited by these symptoms. And we found, again, what we expected based on what you all told us at all these meetings, that almost 3/4 of patients had some limitation to their quality of life because of these symptoms. Roughly 40% of patients reported a moderate to severe limitation of quality of life based on these. One particularly, I thought, poignant example of this, and I think something that helped me, as a person without AMN, better understand the impact of these symptoms, was we asked patients who experienced either urinary urgency or fecal urgency, we asked them, how much warning time do you have between that first sensation of I need to use the restroom and the time where you will inevitably become incontinent if you don't make it to a restroom? And for urinary urgency, patients reported an average warning time of 3.8 minutes, and for fecal urgency, a warning time of 3.2 minutes. So, again, as someone who doesn't have AMN myself, I think that was particularly striking and really helping me understand, just what it means to live with these symptoms. We also asked patients whether they had used any medications or other coping strategies to manage these symptoms. Just over half of patients have tried at least one medication, and about 70% of patients have tried some sort of lifestyle modification. So that might be, something relatively benign, like cutting out or limiting caffeine as part of their consumption, or limiting their fluid intake during the day. For some patients, this was, as severe as planning the entire course of their day based on the proximity to a restroom. So again, just sort of trying to put, a personal take on these symptoms to understand what an impact it might have on someone's life. Next, as I mentioned, we studied the urodynamic studies. And so for those of you who aren't familiar, I think Dr. Gomery will be an excellent person to sort of answer any questions about what that experience is like. But this is a procedure that can be done on an outpatient basis during a clinic visit. It involves several different sensors that allow us to measure the pressure in the bladder, the pressure in the abdomen, as well as the urinary catheter. And so over the course of the study, the protocol involves the patient completely emptying their bladder. And as they're doing this, we're measuring, different variables like the urinary flow rate and the change in pressure, between the different compartments of the system as this is going on. Following complete emptying, We then do a controlled filling phase. And so this involves using the catheter to fill the patient's bladder to get a sense of how much total volume it can hold. After that, we allow the patient we sort of mimic the normal process of what it would be like to avoid urine. And so during that, we're able to measure things like how do the changes in volume and the changes in pressure of the bladder change during that process. We measure when a person first feels a sensation that they might need to urinate, how full is their bladder at that point? How full is their bladder when they first feel a desire to use the restroom? And then finally, what is the volume of liquid in the bladder where incontinence is absolutely inevitable? And so you can imagine that by measuring these variables, we can sort of start to get a sense of, why is it that some patients with AMN develop urinary urgency and then some develop more of a urinary retention where you're unable to completely empty the bladder. And, I think these studies are a really excellent way for us to look at those. And more importantly, to start to be able to treat patients individually based on their specific constellation of symptoms. So based on these urodynamic studies, we actually found an interesting pattern of three different patterns of symptoms that tended to appear in patients. So the first pattern, so I guess I'll start by sort of, the very basic principle here that I think is important to understand is that in order to empty your bladder, several processes have to happen, and they have to happen at the same time or in synchrony in order for the process to function properly. And so the bladder itself has to contract in order to let the urine down. And then the urinary sphincter has to open to allow that urine to actually exit the body. And so the first pattern that we see is patients whose bladder is uncontrollably contracting. So even when they're not trying to pass urine, they're having these involuntary contractions. In some patients, this causes incontinence. In some patients, it doesn't. So we would expect these patients to have more of a picture of urinary urgency, urinary incontinence. The second pattern is, in some sense, sort of the opposite, where the bladder just isn't able to contract appropriately during the voiding process. And so for those patients, we might expect symptoms more like urinary retention or urinary hesitancy, where it's difficult to start the stream of urine. And then the final pattern that we see is a lack of synergy between that contraction of the bladder and opening of the urinary sphincter. And so based on these three patterns of symptoms, we look at our patients and we realize that it isn't one pattern that's present in all men with AMN. It isn't that all three are present in all men with AMN, but that each individual patient has a unique combination of these common patterns that we see. And so I'll sort of wrap up my discussion here, with a note about, I think, why these studies were so, sort of key to our understanding of urinary symptoms in AMN. And that is that doing these studies allows your physician or your urologist to not just listen to your symptoms and sort of try to find a medication that might work for you, but rather to look at exactly what is the process going on in your body and be able to target your symptoms with a first-line medication that's most likely to be effective. And so hopefully that was a pretty basic overview, I think, of the research questions that we were approaching and some of our preliminary answers. But Dr. Gomery and I are both here, and we would love to sort of have an animated discussion with all of you and answer your specific questions about what these findings might mean in your everyday life. Thank you.
Thank you, Camille. That was great and very extensive, hit home for sure for me. It seems like I'm sure many of the men that are on this call, we plan our day around where the bathroom is and making sure. A couple questions came up that maybe either one of you can answer. One is that I found Botox injections annually has significantly reduced frequency and urgency. Been using cath for about 10 years. So that's all one question. So anybody, Dr. Gomery, do you want to comment on that? Or
I would like to say that I'm glad to be invited to this session. Thank you. I think it's really important to understand that, as Camille emphasized towards the end of her little presentation, that we don't necessarily treat the symptoms as much as what we find to be the dysfunction in the lower urinary tract. So Botox is very useful as a second line of treatment in patients with detrusor overactivity, or even just what's called sensory cystopathy, which is exactly as the person who asked the question. It's where the sensory part of the study shows urgency. In other words, as Camille described, you don't reach, you reach that level of first sensation and first urgency rather quickly in the filling process. So their Botox can be very useful if any of the oral agents or combinations of oral agents do not help. It's the point about annual. We do not set a limit to the interval because each patient is different and each patient sets his own limit. So when you start, we inject you with Botox, you reach a certain level of efficacy, and when that level of efficacy begins to wane, obviously that's the time for the next injection. That interval can vary anywhere from 3 to 12 months.
Okay. Another question that came up was recommended to do the urodynamic study. This says in the New York or New Jersey area, but maybe you could just, in general, where can people get that study done, no matter where they are in the country?
Well, I think obviously you have to consult first and foremost with your neurologist, because any neurologist who is seeing a patient with AMN obviously has a referral line to a urologist. But I think it's really important that people in academic centers, in the big centers, obviously have more experience with these rather esoteric and eclectic diseases. So it's always preferable to go to someone in an academic center. The New York, New Jersey area is riddled and studded with academic centers. So, you know, whichever one you get referred to is okay.
Great. And one of the questions that came up is, what are some methods or medications that can address bedwetting?
Bedwetting is just one of several symptoms that denote lower urinary tract dysfunction. It is rarely an monosymptomatic as such. It simply connotes more urgency and therefore likely detrusor overactivity, though it can also imply detrusor underactivity in the sense that your bladder no longer senses well. It fills to a large volume and then simply you leak because the volume overcomes the ability of the bladder to hold. So again, treating symptoms in of themselves is risky. We like to treat the finding, as Camille described, in the urodynamic study, because we can actually make the wrong decision based just on symptoms. We do treat, we have ways of treating bedwetting, or what we call nocturnal enuresis, if that's a symptom all by itself. But again, I wouldn't recommend that.
Okay. And another question that came up is a urinary catheter necessary if opting for Botox? And just maybe your thoughts on urinary catheters in general, that would be helpful.
Okay, wow. That's a big question, urinary catheters in general. Urinary catheters are useful when they're useful. We don't like to use them unless we absolutely have to. We have all sorts of ways of using them. We have what's called clean intermittent catheterization, which is you insert a catheter to drain your bladder at certain time intervals, 3-4 hours. We have indwelling catheters that can either be urethral or suprapubic. What was the first part? Is a urinary catheter
necessary if opting for Botox?
Well, no, it's not. I mean, the Botox injection is done. We first insert a cystoscope, a little telescope in the bladder, through which we can put a little needle that we can inject the Botox through. So when we do end up injecting the Botox, there is no catheter, but we do have to place a little endoscope in order to be able to visualize the bladder so we can see exactly where we place the injections.
Okay, with that, I do have one question with regards to is there connectivity between issues with constipation and urinary urgency, and maybe you could discuss get into any treatments around it.
There is great connectivity because there is very astute research now that shows that there is crosstalk with neurotransmitters between the nerve bundles that leave the lumbosacral area and go to the gastrointestinal tract on one end and to the genitourinary tract on the other end. So if one is awry, the other one will go awry. So it's crucial for people who have urinary tract symptoms to ensure that their bowels are working properly, that you take the appropriate supplements so you don't suffer from constipation. Because the moment you're constipated, in the olden days, it used to be thought that constipation, because of distension of the colon, caused pressure on the bladder. That's not at all the case. It's much more complex than that, as we've learned from molecular biology in the last 50 years. And so there is neurotransmitter receptor crosstalk, and it's very important as a result of that bowels be properly working in order to avoid urinary tract problems. And we emphasize in our treatment of urinary tract dysfunction very heavily the appropriate attention to bowel regimens.
Great. And I'm sorry, there's some Q&A that came in. I was using the chat, but there's also Q&A. So any of the other medications that we would take for gait and spasticity, like baclofen, for example, have an effect on urinary or bowel symptoms?
There's been a lot of anecdotal discussion about that over the last 30 years. There is really no good evidence-based knowledge to assert that baclofen impacts upon lower urinary tract symptoms. I always note it, but I do not in any way, I would never tell a patient to either not take the baclofen or to lower or increase the dose based on my need to help with the urinary tract symptoms.
And then there's just a question or just a thought about bladder massage as a good technique. Is that any thoughts you have around that?
Gee, I'd like to know what bladder massage consists of.
I don't know.
Okay, no, I'm only kidding. I mean, it's not. There's no such thing as bladder massage. There is such a thing as the Crede maneuver, CREDE, which is a way of pushing on the bladder in order to fully empty for people who are unable to empty well otherwise. And it's very important to teach people to do the Crede maneuver properly, because what always happens is that people tend to use their digits. The digits are the weakest part of the hand. So you have to use the heel of the hand, and you put the heel of the hand right above the pubic bone and press down. And that exerts enough force to be able to fully empty the bladder. And it's a very useful maneuver for people who have what's called an underactive bladder, meaning unable to empty.
Okay. Another question, would you recommend urine sheaths or urine bags for men with AMN?
Urine sheaths and urine, it's very hard to recommend in generalities. I think the important thing is to get yourself a urologist who cares. The problem is that urology is by and large a specialty, it's a surgical subspecialty interested in acute surgical problems. This is a chronic problem. It's hard to find urologists who are really interested in the care of chronic problems. And it's important in this kind of a disease process to find yourself somebody who's truly caring long-term and who is willing to try multiple methodologies in order to solve your problem. For instance, we are in the process of establishing a center at Massachusetts General Hospital for this kind of chronic care because it takes a lot of resources, it takes finances well above and beyond what insurance pays in order to attend to the patients daily to all their needs and to these specific issues. What should I use? What's available in the marketplace? How do I deal with all these difficult questions?
Great. Okay. Just anything, doctor, that you want to share? I know we went right into Q&A, but on how people typically deal, although I know there's no typical because there's studies that are done, but any treatments that are typically used? Let's use.
Well, I think we covered some of them. We typically start with oral agents. Obviously, I mean, we can also start with things like physical therapy. If you have available to you a good pelvic floor muscle therapist, there are now all over the country specialists in that arena. They're very well trained and adept now at trying to help you, but obviously they have to understand the problem too, because if they try to take care of you just simply by saying, well, I can use this method or that method, not knowing what exactly is wrong with you urodynamically, they can also make mistakes. So again, that's why you need a multidisciplinary team. And in order to find a good multidisciplinary team, again, it takes resources. The big centers have resources. Even they're suffering from difficulty with resources today because as you all well know, the healthcare world is in a difficult situation financially, and we're trying to figure out how to manage it. So again, it's best to really go to people who are willing and interested in doing this. We get people in Boston from all over the Northeast corridor because people end up willing to come because they know that they'll get attention from a multidisciplinary team.
Dr.
Yeah, go ahead.
I was going to say, I think one topic that might be helpful for some folks in the audience is I wonder whether you might be able to do sort of an overview of, if a patient with AMN gets referred to you, what does that process look like? And, what do you do at the first visit? What should they expect?
Good question. So first visit, we talk, I listen, I find out what the symptoms are in order to decide how to approach it, depending on, the intensity of the symptoms and such. And then obviously, as we've discussed now for several minutes, we go to the urodynamic study to find out what's wrong. We'd like at first to really start treating with what's called first-line therapies, which are really oral medications, which a lot of people deal well with. They with them. Sometimes you get adverse events. We have several different lines of doing that, and we like to stay on that as long as we can. We only go to second and third line therapies, such as Botox and then neurostimulation, if we absolutely have to.
Okay. What other strategies are recommended in terms of coping with?
I'm sorry, I lost the first part there.
I'm sorry. What other strategies are used to cope with both urgency as well as lack thereof flow that you're seeing?
Strategies all start with behavioral strategies. Urgency, as Camille pointed out, one of the key points is that warning time. How much time do you have between the moment you experience urgency and the moment you must be at a toilet? Obviously, that is affected by your level of hydration, number one. So unfortunately, we don't like people to run themselves dehydrated. We want you to be well hydrated to protect your kidneys, because that is first and foremost in your urinary tract. We need to have good kidneys. So we don't want you to be dehydrated. You can't increase your warning time by running yourself dehydrated. So then comes things like, well, then you have to urinate with regularity, perhaps prior to having the sensation to urinate. In other words, train yourself to urinate by a clock, whether that alarm goes off every 30 minutes, every 60 minutes, every 90 minutes. You have to find out for yourself, because the warning time differs for each individual depending on their neurological condition. The other issues are also, for instance, because our vascular tree doesn't work well as we get older, and our legs accumulate fluid that comes out of the vascular space, so-called peripheral edema or swelling. It's important whenever you're sitting to raise your legs so that all that fluid has a chance to go back to your heart, kidneys, and bladder, and you urinate it out during the day rather than at night when you've become recumbent. That way you avoid things like what we were talking about before, bedwetting, nocturnal enuresis. So there are all these behavioral measures that you have to take into account. Even things, today we're getting smarter and smarter about sleep disorders, because a lot of times people actually wake up at night to urinate, not because they have to urinate, but they wake up because they're not sleeping well, and then they have to urinate. So it's well worth it sometimes to undergo a sleep study, find out what's going on, and avoid. That's a good strategy to avoid waking up at night multiple times.
Yeah, that's interesting. So I've heard that from a lot of men talking to that they're struggling with getting up multiple times during the night, and therefore they're tired the next day. And you think some of that related to sleep disorders that might be?
It can be, yeah. It can be. Sleep disorders, we knew nothing about sleep disorders 30 years ago. It's becoming a very interesting learning experience to find out what constitutes a sleep disorder. Our technologies to document the various kinds of problems, the various sleep apneas, are becoming more sophisticated. And it's really a very evolving science. So not that we know a whole lot. First of all, we don't know a whole lot in medicine in general, but we're learning a lot. So all these things come into play to do the right thing instead of jumping to more invasive modalities.
One of the chats that came up from a ALD, a female, is that my urologist put me on 50 milligrams of Myrbetriq samples, and it's beginning to work after nearly 2 months. I'm on Myrbetriq, the same thing, and it has been effective and helped quite a bit. Just any thoughts you have on that?
Sure. Myrbetriq has been around for 8 years now. Originally, it was a real breakthrough, because until then, we only had, this is for detrusor overactivity, we only had anticholinergics, which have some side effects. The anticholinergics act on a certain class of receptors called muscarinic receptors. They're anti-muscarinic, which are prevalent in the bladder. We found out purely serendipitously that there were these beta-3 adrenergic receptors in the bladder also. So Myrbetriq directly acts on a different kind of receptor, doesn't cause adverse events practically, and it is helpful sometimes either alone or in combination with an anticholinergic. And it also can be, the dose can be increased safely to many times, I'm not going to say how many, but many times 50 milligrams, because the pivotal trials included doses much higher. The competitor to Myrbetriq just came out 2 months ago. It's called Gemtesa. It's called Vibegron. So it'll be an interesting addition, see if there's any difference in that. But they're only now those two beta-3 agonist drugs. And they have made a big difference, yes, as Tim would attest.
I'm curious why, maybe the leg issue you referenced, I'm kind of curious, when you have to go, you have urgency, but it impacts your mobility. It's tough. If you wait too long, your legs don't work well enough. Why is that?
Camille, you want to answer that one?
Could you repeat the question, Tim?
So if you have to go, you have an urgency and you have to go to the bathroom, your legs don't work as well. The longer you wait, the worse it could be.
Yeah, absolutely.
Recommendations?
Yeah, I mean, that's one of the things that I think makes these symptoms in AMN so unique and so challenging in a way that they're not for, perhaps people who have these symptoms but not AMN. And, I think that's something that, a lot of like different behavioral changes or lifestyle modifications might be able to help with. I've definitely heard patients talk about keeping diaries, for a few weeks just to kind of monitor, when is it that they have the most urgency? Is it, X number of hours after, a big meal or after certain activities? And, I think that is, a low-tech solution, but one that, might be helpful in sort of identifying when are the times that is most likely to happen, so that you're sort of able to then plan, different aspects of your day around that. So not necessarily preventing it from happening, but being prepared when it does.
Yeah.
The other fascinating point to that question, Tim, is that we're just beginning to find out how the different areas in the brain interact. We know very little about the neural circuitry of the brain, and we're just finding out. So again, your question speaks to that. How do the nerves controlling mobility interact at that point when you're experiencing urgency, when parts of your brain are saying, you gotta pee, you gotta pee. And so what's interesting about that is that many years ago, somebody thought about that point and said, why don't we do a urodynamic study in an MRI machine and observe through functional MRI what areas of the brain light up when a person has either the sensation to urinate or the desire, the urgency. And interestingly enough, obviously, a lot of areas light up, and we're just beginning to learn how those areas interact at that moment. And obviously, in the future, if you transpose that further out, I mean, this is all going to be artificial intelligence work that's going to be fascinating so that we can literally change that circuitry.
Great. Well, when I have to, a lot of times I'm mentoring young men or that are going through changes. And one of the questions that always comes up is ED. And can you address your thoughts on that, treatments that are used maybe beyond oral? We know the typical oral treatments that are available, but beyond that, and other issues about sensory, not only ED, but the sensory decline, if you would, with AMN men.
I'm sorry, can you elaborate what you mean by sensory decline?
Yeah, the actual feelings in the penis because of AMN.
In terms of sexual function?
Yes, yeah.
Okay, that's a tough question. We know much less than we don't know about sexual function in men in general. We do know that there are 4 different components to sexual function, and they're all neurologically distinct and different, so that you can have a neurological problem affect one or any of the other 3, and permutations and combinations thereof. The 4 components are obviously libido or desire, erection, ejaculation, and orgasm. And again, the important thing is to understand that they're all separate neurological functions, though we men, because we experience them very close together, tend to lump them together. The only one we really know how to treat a little bit is erection. We don't know how to deal with ejaculatory dysfunction, orgasmic dysfunction, or what I think you were referring to before, Tim, sensory decline or libido, which is lack of desire. Those are all really complex. Lack of desire has been addressed since 1995 because the pharmaceutical companies found a way to make testosterone replacement readily available without having to give intramuscular injections. Unfortunately, it's become more of a commercial enterprise to give men all these testosterone replacement therapies, which we don't know what the adverse events are long term. And they're given, obviously, for very vague symptoms: fatigue, I don't feel good, I used to feel better. Very little in the way of real biomarkers to treat. We'd like to reserve testosterone replacement for what's called true hypogonadism, meaning absolute decreases in the value of your serum testosterone. So the treatment of ED, of erectile dysfunction, basically is the 4 drugs that are available. They've been available for now a couple of decades. They're only 4. They all act a bit differently, so they're worth trying in succession, because depending on your own genomic makeup, one drug may not work at all and the next one will. So don't get discouraged when the first one doesn't work. It doesn't mean that the other 3 will not work. It takes systematic. Same thing goes for the urinary tract. The drugs have to be taken systematically. And unfortunately, what ends up happening, and I think Tim or someone said at the very beginning, my doctor gave me Myrbetriq samples. If they only give you for a couple of weeks, it's worthless. I mean, you have to try these drugs at least for 6 to 8 weeks, especially the urinary. But same thing with the erectile ones. We recommend that you use them at least each one 8 times before you discard a particular drug. After you've tried that, if that doesn't work, we go to what's called intracavernosal injections, which are injections of 3 very powerful drugs into the penis directly. because obviously you're acting directly into the vascular tree there in the penis. The penis, in a simplistic sense, is nothing but a receptacle of blood, and it's blood flow that has to be increased. And the penile artery is a tiny, minuscule, millimeter wide artery. So you need what's called a good vasodilator, and we inject a combination of either 2 or 3 drugs that directly impact there, and it has been very effective. That therapy has been around since 1984, so it's now 37 years. When administered properly in the right dose, it's very safe. And then after that, if that doesn't work, we go to surgery. But we really like to restrict surgery today to those cases that have failed both first line oral agents, second line injections, and then surgery.
And a urologist is the person to address. I'm getting a little of that too, ED. Okay.
Correct.
And then just somebody gave a suggestion. I suffer from ED and
Alprostadil.
Injections can help those suffering as well.
Alprostadil is one of those 2 or 3 components of the injectable vasodilators that I mentioned.
Got it. Okay. So in any case, if you're having issues, you should see a urologist about that. Okay.
Definitely. And
Okay.
actually, I'm sorry, Tim, to interrupt, but that is a very important point, what you just said, because there are now businesses all over the country that direct, and you see these ads on TV. Now, I started my own company directly addressing these issues. You've got to be very, very careful not to fall in the hands of business, especially with a disease like AMN. You need, like I said before, and I don't know how to reiterate and emphasize that point. You need care, and you need long-term care. You need someone that you are comfortable with, that you trust, and that is willing to go to the nth degree with you to address the issues.
Yeah, I couldn't agree more. I'm blessed with a great urologist who really cares. Getting back to some urgency, another question came up. Can Myrbetriq lose its efficacy? What's the maximum dose? I'm experiencing more urgency counting my nighttime bathroom visits, which shows more urgency. I have to tell you, this person's reading my mind. This is exactly the way I feel. I'm counting my, it's 4 or 5.
I lost you there. You went out, Tim. Are you there? Camille, can you hear me?
Yeah, no, I think he's frozen for me. I think we got it
there
back.
you go.
I thought it was my internet. Okay.
So, first of all, Tim, I think it's important. The reason people are reading your mind is because you have such a beautiful smile. Number 2, vis-a-vis the point of Myrbetriq tolerance, it's important to realize that we don't know enough about how to measure tolerance, but oftentimes it's not the tolerance that's the issue, it's the disease progression. So that's, again, you need someone who cares, who you trust to understand that point, that you may have to increase the dose of Myrbetriq. Now, because the FDA only authorizes certain doses, I cannot in public give out doses that are beyond what the FDA authorizes. So I really don't want to do that here.
Yeah.
That is a topic.
Is there a maximum?
Of course there's a maximum, but that's a topic that you have to discuss with your trusted and knowledgeable urologist as to how far you can go. But I can tell you that in every specialty in medicine, in every drug class, people use doses that are beyond what normally is suggested.
Gotcha.
I can't say any more than that.
That's fair. Another question came up, switching topics. What about fecal incontinence? What type of measures can be taken to help?
Again, first and foremost, you need to see, there are now gastroenterologists who specialize in neurogastroenterology. I'm a neurourologist, meaning a urologist who specializes in the diseases, in the urinary tract complications of neurological diseases. Gastroenterology has been late coming into this arena, but now they exist. They are, again, people who are willing to address the chronic care needs of neurological diseases. And you're often best served by someone like that who is willing to go to bat with you long term. So again, fecal urgency and fecal incontinence need to be addressed, are extremely important in terms of proper urinary tract function. And again, avail yourself of someone who specializes in that arena, because otherwise you end up with a gastroenterologist who just wants to put an endoscope in your mouth to look at your upper GI tract, an endoscope through your rectum to look at your lower gastrointestinal tract, which will help you not at all.
And then this is a
neurogastroenterologist.
Got it. I have to tell you, I have a great friend who's a assistant chief at a hospital, GI, and he recommended a simple over-the-counter thing, which every night I haven't missed in 15 years, Miralax.
Right. And before Miralax, there is stool softeners, stool promoter. You go to any drugstore in the United States, there's an aisle full of these GI products. Yeah. So you start with a simple stool softener. Then you can add and take both a stool softener and a stool promoter. Then you can go to Metamucil. Miralax is even third line. Really? So there are multiple products to try and everybody is different. So every individual has to find out for himself empirically which of these supplements or combinations thereof works best.
Yeah. Yeah, that was okay. And then I'm sorry. Okay, they did spell it. Thank you, Camille, for spelling that for us. The newer drug. Let me make sure there's not more in the Q&A. Okay, Dr. Gomery, as we kind of finish up here, we maybe a couple minutes of advice. And then we're really at the end of our session here. Corey doesn't see it. It's Corey. It's G-E-M as in Mary, T as in Tom, E-S-A.
Correct. And the generic name is Vibegron, V-I-B-E-G-R-O-N. Any
last bit of advice, Dr. Gomery, before we conclude our session? This has been excellent.
Camille, you go first.
Sure. Well, I will say, I think I really love the emphasis that Dr. Gomery has placed on, finding a provider that is willing to work with you and kind of in it for the long haul. I think that is really the most key thing here. But I will also add, I think I've been so excited and so empowered just to see, all of you come together in the ALD Connect community, to bring attention to these symptoms and to, sort of hold, providers and researchers accountable for, what really should be at the front of our minds, when we're thinking about AMN and different symptoms. And so I guess my advice would be, on a personal level, find someone who cares about you and is able to help you face these symptoms together. And secondly, keep speaking up, keep telling us, what you need to see, what you need to hear. Because I think, hopefully this is a testament to, we're here to listen, and, we just want to make sure that, research and clinical care is going in the direction of the things that matter most to you. So from the bottom of my heart, thank you all for, opening up and, sharing with us about these symptoms that can be, vulnerable, sometimes embarrassing, and just really allowing us to tackle this together. So thank you.
Thank you, Camille. That was great. You've been terrific. Dr. Gomery?
I can only say that I wish I were as eloquent as Camille.
Well, you two have been terrific. I have 4 pages of notes here on my page, so I'm very grateful personally, and I know those men and women that are on the phone today, I'm sure got a lot of good information. Clearly, this has been very helpful, and there's a lot of nice comments and a lot of thank you. So thank you on behalf of ALD Connect, on behalf of the patients, and we really appreciate you taking your time out on a Saturday. Have a great day.
Thank you.
Thank you all, and thank you, Dr.
Take care.
Gomery. Thank you, Tim.
Thank you.
All right.
Take care.
Thank you.
Bye.
Bye.